However, in this case, my first option was to retreat this tooth conventionally through the crown, and a new crown was recommended to the patient. However, due to financial restraints, the patient was unable at the time that I was making the recommendation to have this tooth treated with a complete retreatment and a new crown. And here shows another angle. As you can see, it's quite a large radiolucency. The borders are well defined, and usually when you see something of this size, you would expect that it would be a through and through lesion, which means that both the buccal and the palatal plate, cortical plate, is gone. So basically, here's another angle as well. What we decided to do was, due to the patient's inability to have the proper treatment done, we decided to treat this surgically, remove the lesion, and essentially do a retrograde filling of the apex, with the understanding that pretty soon the patient was going to have the regular orthograde retreatment and then a new crown. So for emergency measures, and because of the fact that the patient had this infection, we ended up having the treatment done first surgically with a retrofilling. Now, as you can see, this is the immediate post-op of the case. The retrofilling is done using the Endosequence bioceramic root repair material only. Now, my new technique that I've developed, as you have seen in previous tutorials, includes first placing the retrofilling material and then the root repair material, and then following that up with a cone of putty. But here, this is one of the earlier cases I have done where I used to fill the entire retrofilling with the root repair material only, without the use of any putty. So as a result of that, unfortunately, we ended up trapping a tiny little void in the retrofilling, which it shows here post-operatively. This, as you will see, is not really a problem. It doesn't look nice on the radiograph, but it seems that it did work pretty well, as this is the case 6 months only, actually about 7 months post-op of the case with the retrofilling alone. It's amazing because I normally do not use any form of bone filling material following apicoectomies. I find that most endodontic lesions are basically 4 or 5 wall defects, and they fill in with bone without any form of bone grafting. And this case was not bone grafted. This actually is the patient's bone that has come back about 7 months post-operatively, and that's quite remarkable because I did not use neither a membrane nor any form of bone grafting. Although during the surgery I found that the lingual plate of bone was not resorbed, and it was only a buccal plate that was gone, and as a result, I think that is part of the reason why we ended up having such a good fill, since it was not a through and through lesion. By the way, the pathology report came back as a cystic lesion, and as you can see, the results were pretty good post-operatively 7 months later. I followed up this patient. Now this is the 9-month follow-up. Here's another angle of the 9-month follow-up. You can see there's remarkable healing here, and the area has filled in pretty well with bone. Now, at 9 months follow-up, I did recommend to the patient that it is about time that we go ahead and retreat this case if she's ready. And having gained our confidence, she finally did decide that she's going to have the proper treatment, which would require the removal of the crown and placing a new one. But I was adamant that we try to retreat the coronal area of the gutta percha, which I knew was going to be infected first, with a conventional orthograde retreatment. And here's basically what we ended up doing. As you can see, I'm using the Race 3508 file. 2 to 5,000 RPM is all you need, but this is a pretty straight canal. So following making the access through the crown, you can see that I've removed all that material from inside of the canal, trying not to go any further than the retrofilling. Here's the ultrasonic to clean the canal even more. And here, basically, because the apex is plugged, the job is to simply clean up the inside of the canal after having removed the gross debris using solvents and a higher speed rotary files. Now we move on to using our disinfectant regimen with hypochlorite and EDTA and further hypochlorite, removing the smear layer and using the endovac with negative pressure. Having cleaned the canal completely, I actually do not use paper points at this point. The endovac and the suction is all I need at the very end. And then I'm using the EndoSequence biceramic sealer, followed with a size 50-04 cone that I'm using to obturate the canal. And then I'm simply searing it off at the orifice level and then following that up with some condensation. Now, this technique requires a good amount of condensation. Any of these techniques that are one cone based require some coronal condensation, as the gutta percha needs to push the sealer or the filler tightly against the canals. I'm using the